I'm Amanda Steen, by the way. I know in your paper it says I'm going to talk about the rehabilitation of spine as well as palliative care, which is an entire residency and fellowship. So I'm going to try and narrow it down a little bit. And I know this morning you've been talking about the spinal procedures and surgery. So now I want to talk about the functional recovery of patients and with spinal tumors. And while a lot of patients are, you could say, fortunate enough to only have their tumor affecting the bone, a good percentage of patients on presentation have neurologic deficits. And then unfortunately some of them may have neurologic deficits even after the surgery. So I wanted to talk a little bit about spinal cord injury rehab in general, and as well as some different things to be thinking about in their post-surgery recovery, as well as then some different highlights of how these patients might be different than a traumatic or non-traumatic spinal cord. And then, I know it's a lot, but maybe highlight a little bit of the different rehab levels of care. How do I change?
So, just go, yeah. Actually, Amanda, if you stand right here.
Yeah.
Then the camera.
Then the camera sees me. Okay. All right. So in spinal cord injury rehab, the goals of rehabilitation are to increase the patient's physical function, alleviate and control their symptoms, help increase their quality of life. This is a lot of goals. Increase physical and their cognitive independence, train the family and the patient for community living, and educate the patient and family about their disease course, recovery, and self-care, as well as prevent complications of their impairment. In spinal cord injury rehab, this is what I tell patients as well, is we want to preserve their body systems and the health of those systems while the healing occurs. We want to also teach them how to care for their body and help them regain as much functional independence as is possible, no matter what recovery they do get. And so spinal cord injury, I know this is a lot of words, but it can really affect all body systems depending on where the injury is. And so as you can see, I've listed a lot of them are on there, and that I'm thinking about as a rehab doc when I'm seeing the patient. And so this comes up when talking about how to prepare the patient for rehab and things that you might be thinking about in the hospital after, either before they go to surgery, after a neurologic impairment, or after. Oops. And I'm going to highlight just some of the pearls because there's lots of words. Hopefully you have access to the slides. They have a lot of pain. Obviously, we deal with a lot of pain after you do surgery, or they have some kind of neurologic compression. So what I generally think about is scheduling pain medications for these patients, because they forget to ask. The time gets away from them. They have no idea when it's been 4 hours. I always recommend avoiding multiple different categories of pain medicines. I'll see people write, number 1, use oxy, number 2, use hydrocodone, number 3, use tramadol. And that just gets really murky when you're trying to find out from the nurse, what did they use and did it work? The patient can't remember if it worked or not. I also recommend people consider using the same class of medications if you're going to use long-acting and short-acting, because that makes it easier to calculate the total daily dose. And then I also want to remember that as the patient's mobility improves, their pain may stay the same. So they keep saying, my pain's no better, but they're functionally moving more. So often people will, they'll get up and get moving, and they'll start tapering them really quickly, and then they'll have more pain. Then also consider their preoperative narcotic use. How much were they really using before you did surgery? Because that goes into how much they may need afterwards. Also anticipate that if you're removing a nerve catheter, their pain probably will go up initially. And multimodal pain management, which is, you guys are also pretty good about making sure that there's a whole bunch of other things. Oops, wrong way. Okay, so then also, that's different than the operative pain, is the neuropathic and radicular pain. Radicular pain, as you're aware, often improves after you decompress the nerve. Neuropathic pain can occur as healing occurs or as the nerve is compressed. And this is really confusing to the patient because they often can't tell, am I healing or am I getting worse? So what I generally tell them is, look, the nerve is annoyed. You can have pain with injury and with recovery, but if you're functionally improving and you're getting stronger, it's probably more of a healing pain, just in general. It can often worsen before it gets better, and opiates are definitely known to be a good adjunct for these neuropathic pain agents. And one thing I encourage the surgical staff is to be patient with these agents, because they can take days, if not weeks, to titrate, and they just don't have an immediate effect. Spasticity is something else to consider in the spinal cord patient. This is the actual definition given by Lance in 1980, but what I tell patients is your reflexes out of control, because it's easier for them to understand. It's just a variability in their muscle tone depending on how fast the joint is moved. The pearls about spasticity I tell people is spasticity never, ever, ever has to be treated. And there are reasons for treating it for the patient, but that by far the very best treatment is range of motion before any other medication or treatment. It's usually lifelong stretching if they're impaired with it, and it can develop over time. It can be very helpful to the patient, and it can be static or dynamic. And the spasms might be painful, and the times you might consider treating it is if it's painful, if it's inhibiting them to move about, maybe it's throwing them around in their chair, if it's impairing their self-care, such as like adductor spasms at the hip, which makes pericare really hard, or if their strength is just so weak they can't overcome it, the tone to be able to move. So the pearls about all the medications is every single medication you would use for spasticity has the potential to cause confusion or sedation. They all need to be titrated carefully and monitored, and generally we don't tend to combine the medications. What I want to say about baclofen is that it's very, very specific in its dosing, and it's really weird medicine. Like it doesn't matter how big you are, small you are, tall you are, old you are. The medication, we all have different doses, and you need to be patient with it. And I recommend people don't change it any more than every 3 to 4 days, because it can build up very quickly in people's systems. The other medications that we use are there, but also to note that typically in spasticity, we don't use the peripheral muscle relaxants that you might use after surgery, like cyclobenzaprine, because those are more for peripheral muscle spasms rather than central. Orthostatic hypotension occurs often after spinal cord injury, and the pearl I want to give you about this is that there's so many reasons after surgery that they might have this happen. We all see this, but in addition, I try to recommend to the team to just treat the patient and not so much the numbers per se. But it's very real after spinal cord injury because of their lack of muscular control in their lower extremities, as well as their vascular response to sitting up can be impaired. And then there's autonomic dysreflexia, which we throw around. I'm happy to say this is the one and only emergency in rehabilitation medicine. It is an absolute emergency. I had a patient recently that he would go to 230 systolic when he got constipated. And this would happen like it was no big deal. And failure to recognize this emergency can lead to heart attack and stroke, which I have seen. It's not the actual number, it's the major change. And a thing it will occur in patients that are pretty much only T6 injuries or higher. So a patient who's in a lumbar spinal cord injury, it will never happen. And it has to do with where the cardiac plexus is up in that level. It usually begins 3 months after injury, but I'm always on the alert that it can happen quickly after spinal cord injury. But it always, always, always is due to a stimulus below their level injury. And it can be, it's just some kind of stimulus, but it's usually noxious. Treating the stimulus will resolve the symptoms. And the common symptoms you'll see is flushing, piloerection, sweating above their level. Like if they're at, say, a T4, they're going to get red and hot and sweaty up above, but not below. And it can often be marked that you can see a redness at a line. And so the key to it is to try to figure out what is going on and not let their blood pressure get dangerously high during the time. And so My key treatment for it, this is online for lots, and I always put it in patients' chart when they're at risk. But the thing I use to treat is nitro paste, because it can always be wiped off the moment that you find the problem. And whenever you resolve the problem, the blood pressure will instantly fix itself. So if you have given them a pill, now you are chasing your low blood pressure and having to give them IV fluids and resuscitate them and whatnot. So neurogenic bowel is something I see very commonly, as you guys also see just post-op constipation, and so I'm always on the alert after any sort of spinal injury. The thing that I deal with in the hospital a lot is someone came in, they had a neurologic injury, they had surgery, and now we're gonna wait and see what their bowels do, rather than being proactive and saying, we know they had a neurologic injury, we know they're gonna be constipated from anesthesia, let's make sure this stuff is on board so that we don't have a post-op ileus 3 days down the road. This is really hard to impart to our nursing staff and whatnot, to say, yeah, I know he had a bowel movement the day before surgery, but he needs these medications and I need you to support me in getting it, because the response to the bowels to any neurologic injury or surgery is to slow down and be uncoordinated. So I'm constantly trying to harp on getting this going. The other problem we have is, oh, we haven't pooped for 3 days. Now we got it going, and they had 3 bowel movements, so we're not going to give them any more medications. Well, the problem with that is you still have a slow bowel, or we may not really be sure, do we have a bowel that's injured from the spinal cord injury, or we don't really know yet, but now that we've stopped all the medicines, now we're going to get back to that loop of constipation, if that makes any sense. So what I generally recommend to the staff is, let's keep us going until things are regular and moving at the patient's pattern, either daily or every other day, and then start to slowly scale things back, rather than this back and forth diarrhea constipation that often ensues. And what this means to you guys is, the longer we have to deal with constipation and these problems, the longer they have to stay in the hospital. And nobody wants that. We want them to move on. So neurogenic bladder is another thing that often keeps them in the hospital. And what I tell patients is they usually go in tandem in a spinal cord injury. So if your bowels are starting to figure themselves out, usually the bladder is going to start to figure itself out too. But if you're constipated, you're going to have trouble peeing. So they all go together. And this annoying thing about the bladder is it's very complicated neurologically. What I usually see happens in the hospital is someone will come in, they get a Foley placed for their surgery, we take it out, we do a voiding trial. After the voiding trial, maybe they pee a little bit. Okay, that's great. We do a couple PVRs, but then they haven't fully been emptying, and eventually it catches up and they overflow, and now they're incontinent. Or we finally do a PVR and see, oh my gosh, there's got a liter in there. And now the bladder is so overdistended that we can't pee. So that is the most common thing I see in the hospital, is trying to make sure that we avoid the distension to begin with. I think we should just assume they probably are going to have trouble and be overcautious about it and make sure that they're not getting this backup fill. So like I said, just like the bowels, the bladder's general response after any spinal injury is to slow down and not empty properly. They can retain urine and have an uncoordinated squeeze, or they can have an inability to void completely. A voiding trial really is the only way to tell if they're able to pee. There's some common medications that get used in the hospital. Some pills, I'll tell you, tamsulosin, it doesn't work instantly. It can take 2 to 4 weeks to reach full effect. So just because it didn't work after the first dose, that doesn't mean we need to give up on it. It also can cause a pretty nice orthostatic hypotension. So we typically dose it at night, so they sleep through that. Also, bothanicol, I would encourage you to read the contraindications to use of this medication, because it has a lot of cardiac contraindications. It also can cause a lot of spasms and urgency. So it's not benign medication. Also in spinal cord injury, I'm really aware of their skin, because they've got abnormal sensation. They may say they can feel things right, but if they've had a neurologic injury, I want to be aware that there could be some issues with their skin. And it's always easier to prevent breakdown than fix it after the fact. We teach the spinal cord injured patients that they need to learn to wiggle and move around, as we all do. So there's some differences in the patients that we might rehabilitate who have spinal tumors as opposed to the regular non-spinal tumor injured patients. Compared to traumatic spinal cord injured patients, the neoplastic ones tend to be older and female, unemployed for some reason. They tend to more likely have an incomplete injury. They tend to have shorter lengths of stay on acute rehab, and they have less functional gains during rehab, but there is pretty close. But a third of their overall survival is spent in rehab. So one of the things we are constantly thinking about as rehab professionals is how much of their life do they need to be spending on rehab to get back home, depending on what type of cancer they have. They do have higher complication rates in ARU, which is true, and they have a higher readmission from ARU back to acute care. But compared to patients who don't get any rehab, when they have a spinal cord tumor, they do have increased survival, increased quality of life, increased independence after their rehab. They're more likely to go home. They maintain their independence in ADLs as well as walking and stairs much longer, and they have better bowel and bladder control. They have decreased readmission to the hospital after discharge. They have decreased death from spinal cord-related complications. They have decreased pain and better pain control overall, and decreased depression. And just this doesn't have to do with rehab per se, but patients who have surgery and radiation, they tended to have an increased survival, longer walking, and better walking and decreased pain. Of patients that have neurologic spinal cord injuries and cancer that were admitted to acute rehab, this is just kind of a summary of how long they tend to live. So it's a very real thing that I think about with the patients, depending on what kind of cancer they have, because I really don't want them spending a long time in rehab. They may go home sooner because we prepare the family better so they could go home at a lower level than somebody else. I would bring your attention to the bottom where 50% of lung cancer patients with spinal cord injury survive less than a month. So it's a very real thing. But prostate cancer patients survive a much, much longer time. And so that's probably why, too, that 50% of prostate cancer patients actually tend to walk. And maybe they spend longer in rehab. Maybe it's because they're going to live longer. Maybe it's because their tumor burden is smaller. I don't know. But of patients who present with their neurologic symptoms as their first sign of a problem, 50% of them are ambulatory before surgery. And those 50% that weren't ambulatory, 50% will regain their ability to walk. However, I should say, even though they can return to ambulation, they almost never have full recovery. So while I have been reading that ambulation is a benchmark for trying to decide whether you should do spinal surgery or not in these patients, remember it's not full and normal ambulation. But it's not back to where they were before. So another thing I wanted to mention, use this as my soapbox, is to say while in rehab, the final pathology may be pending. And I'll tell you, they ask every day, do you know my pathology? Do you know what it is? We usually have a pretty good idea what it is, especially the metastatic patients. We have an idea. And so I put out there, whose job is it to tell them? And I don't know the answer to that. I think it's the team's job to discuss who's, I don't feel it's primarily my job. It's not the oncologist's job. You probably feel it's not primarily your job. I don't know. But that is a question they are asking. And they want to discuss diagnosis and treatment plans, which we don't all know the answers to that either. I'm constantly saying, wow, we need to talk to oncology. I don't really know. They want to know about the timing of chemotherapy and XRT. But I will say that when they're in rehab is when they really start to process the magnitude of what's happening to them. Because at first they came in, they had this neurologic injury, oh my God, I have a cancer, cut it out, get rid of it. And then the dust settles and they start to really think, oh my goodness, what's going on? So cancer patients have other issues that I have to consider on rehab. They have a lot of fatigue, and that I would say fatigue is the biggest problem I have with trying to decide what level of care they should be at for rehab, because some of them just plain can't do it. It's too hard. They have electrolyte abnormalities and cytopenia, vitamin deficiencies, and malnutrition. There we go. Sorry, it's reminding me I'm supposed to be done. Sorry. Depression, they can get wound dehiscences and DVTs. So like I touched on before, pain is a very big and real issue for them. 90% of the spinal cancer patients will have pain as an issue, and they have lots of different kinds. So trying to figure out which kind of pain they're talking about. Is it localized pain or mechanical pain? Is it radicular pain? There are multiple different ways to treat it. And then my last little bit, I want to touch upon the rehab levels of care. Just, I don't know if any of you guys are familiar with some of them, but this is what I do every day, trying to find the right level of care. And my goal for the patients, this is what I tell the families, is let's find the right level of care for you at the right time. You need to be able to tolerate the amount of therapy that's given to you and be able to be medically managed at that level of care. And the goal of any rehab is to be able to transition you to the community if that's what the patient wants. I also consider a place that's convenient for friends and family to come and visit, because especially if you're not going to live all that long, you want to be able to have people coming and visit you and have this support network around you. You don't want to. Most people don't want to be by themselves all day long. So the acute rehab unit is what everybody always says, oh, that's the gold standard, let's go there. But it may not be right for the patient. So patients have to be able to tolerate 3 hours a day, at least 5 to 6 days a week of therapies. And this therapy is spread out throughout the day. But the nice thing about acute rehab units is they're all the same. We all have the same regulations across the country. So I know that here in Rhode Island, this is the care that they are expected to get. They have to have 2 disciplines, at least PT and OT, not just one. And they still need to have some complex medical management that I can take care of while they're up there. So you guys don't have to fix all the problems. They just have to be stable enough that they're not going to keel over while the therapist is working with them. We ask that they have a reasonable disposition plan, because most patients on acute rehab are only going to hang out for a week or 2, and then they're going to head on home. But we're all regulated by the same bodies, so we have the same structure. The problem with and all of the admissions have to meet this criteria. It can take a couple days longer because we have to get insurance authorization, but that's true at skilled nursing as well. So the problem with skilled nursing facilities is they are not all centrally regulated, and they all decide individually how much therapy they want to provide for the patient, and it's all based on insurance or staffing or whatever. There's multiple different things, and since they're all different, we never really know how to recommend them for patients. So that's one of the things I do. They may or may not do different things like trachs or wounds, but they most of the time do not provide one-to-one supervision for the patient. And the vast majority of them do not have physiatry consultants. They're usually internal medicine or geriatricians. There are 5, I think 6 now, skilled nursing facilities in Seattle that have physiatry consultants that go there. And we're trying to get into that so we can provide better care for these patients. The next level of care is long-term acute care, and the difference between that is it's more medical, less therapy. So these are the medically complex patients, the vented patients, the wound patients. Most of them don't provide therapies, but some of them do, like Regional does here in Seattle. And then the difference, the next level of care would be a nursing home. And that's, I think, one thing where patients get confused. A nursing home is not a skilled nursing facility. A nursing home is a place you live. A skilled nursing facility is a place you get rehab. But they can be in the same building, and they often are. So it's very confusing to people. But the nursing home, people can get, it's just like being at home and getting outpatient therapies, essentially. But the therapies are in that building. So they might have therapies 1 to 2 times a week. But they don't do any complex care there. Once the patient returns home, they have 2 options, which is home health therapies or outpatient. And what I tell patients, home health is pretty good because it's in your own environment. So it's great if you've got new neurologic impairments or you're at wheelchair level and they need to help you figure out how you're going to do things in your own home. But it's kind of like waiting for the cable guy, where you're like, I'll be there between the hours of 12 and 4. And you never know when they're going to show up. So that's why you're supposed to be homebound in order to qualify for this. And then outpatient is great because you have an appointment, you show up, they have all the equipment there. But some general pearls about levels of care is you generally cannot go home and then go to SNF or ARU, okay, generally, but people do sometimes. You can't do home health and outpatient at the same time. You can't go from outpatient to home health. You can't go to SNF, from SNF to ARU, although people do. And you should not plan on going to one and then the other. We generally want you to choose one that your hope is to go home after. And a general caveat is to not really expect your patient to improve more than their premorbid baseline. So I'm not a miracle worker here. I can't make your patient run a flight of stairs if they didn't do it before. And the goals of rehab, just one more time, are we want to begin the therapy and recovery process as early as possible because motor recovery is use dependent. We want to attain functional recovery and compensation enough so that they can discharge to a safe environment, and that's different for everybody and depends on their environment. We want to help manage their ongoing issues. We want to educate them about their disease, lifestyle changes and whatnot, and support them in this time of adjustment, and prepare them so that for that next phase of their life. I think that's it. So, hope that wasn't too insanely crazy. So, anybody have questions or clarifications? Yeah.
It was a great overview and it's enlightening for surgeons. I've tried to use that line to them. Maybe that's what I should use, but I want your advice on, you say the right person for the right thing. So sometimes families will get very upset if they're being told they're going to a SNF versus acute. And I'll say something like, well, you're supposed to be able to do 3 hours a day, 5 days a week. And if you don't, they're going to throw you out into a SNF. Mm-hmm. So I kind of get this like little tough love thing. Yep. But I guess maybe the advice would be somewhat similar to you said, that we need to treat you with what the therapists think is right and the physiatrists think is right. And if it's too much, it's too much for you. And if it's too little, it's too little for you. And that's the recommendation. Is that what you recommend us to say?
What I'm trying to change in my consults is this idea that there's this amazing acute rehab and then the rest is a place you go to die. It's not like that. There are some very, very good skilled nursing facilities providing that care for at the level the patient needs. And now that I'm working at skilled nursing, I'm seeing a lot of that going, yeah, this is exactly the type they needed. And I'll admit, we did it to ourselves in rehab because I was taught in residency that SNF was the enemy. And so I didn't have any training in SNF. So I try to tell the patients, look, we want to help you find the right place for you. And I get that there are in the media and there have been places out there that grandma went and she died and it was awful and they neglected you, but that's just simply not true for the majority of places. And I don't want them to come to rehab spending 2 weeks getting ready for rehab. And then when they're finally ready to tolerate it, sorry, you got to go home because your insurance only gives you so much or whatever. I want, when you get to acute rehab, to hit the ground running and be able to tolerate it. I had this conversation yesterday with a patient who she can barely sit, and she can sit with max assist by 2 people, which is total assist. And that's all she can do. And I was like, I'm going to spend the next 2 weeks on acute rehab getting from sitting to standing, rather than having you work up to this stuff in skilled nursing for the next few weeks. And when you hit acute rehab, then we'll work on walking and we'll work on your transitions, and so you don't need 2 people. And so I try to frame it that way, but it is really hard because patients have this preconceived idea that it's going to be, I'm abandoning them. Go ahead, Jeff.
Hey, Amanda. Thanks for the talk. It's refreshing to have like a non-surgical talk on these topics where we feel like we know, but we really don't. We do have a subset of our patients who we send home, who you think they're ready for home. Maybe even the therapists think that they may be ready for home, but they get home and then they have problems, right?
Yes.
So they may, and then through our offices, we try to set up to try to get them to sniff. That's impossible. Try to get home health, and that's impossible. Are there any other solutions other than them being readmitted to the hospital?
Well, so you can actually get you can get admitted to home or from home to skilled nursing. You can. I think though some of it has to do with how long they were admitted to the hospital to begin with. Because if they were on observation status, then that doesn't count. But there are a number of our complex spine patients who they really think that they're able to go home, and they get there and realize they can't do it. I think yes, you can. There is ways to avoid being readmitted to the hospital.
How do we do that? Specifically here.
I think specifically here. I think we're talking to the social workers about, okay, can we talk to some of the skilled nursing facilities and see if they would be willing to admit them? And we do that at the skilled nursing facility I work at all the time. They'll come from home. But I think one of the ways to avoid it, if we can, is to, when we're setting them up for surgery, I mean, some of our patients come in through the ER and they don't have this time, but to when we're setting them up to say, hey guys, this is a really big surgery, and I know you plan on going home, even if it's a little one, but if you're not gonna go home, what are some alternatives that you might consider so that it's not, they're not going in with this set idea that they're going to get fused from C7 to sacrum and they're going home after that. And so I just think that's an unrealistic thing, to do these giant surgeries and you're going to go home. Or you have metastatic cancer and now you've got a compression and you're going to go straight back home. I think it would be way better to be like, hey, I know you plan to go to rehab, but guess what? You're doing awesome. You're doing so well. What do you think about going home instead? And then they're like, huh, well, I'd never really given that much thought. Okay, well, we could do that, rather than saying, I'm sorry, you have to go to this sniff, and you never planned on it. So there's my plug. Social work.
What's the percentage of patients go from sniff to rehab?
It's actually a really small percentage of patients that go from SNF to rehab, and I've been kind of wondering why my admissions planner asked me that yesterday. Why don't we have more? One reason is that once patients are in skilled nursing, the skilled nursing facilities don't want to let them go. Right? They want to keep them there. A second reason is I really become thinking that very often we pick the right place for them to begin with, and maybe their trajectory is so slow that coming to that, they never really got to that point of being able to handle that intensity. One other problem, though, of having rehab physicians like myself in the nursing homes is if I manage all of their spinal cord needs and it's all managed, then the insurance says, there's no medical need. Why would they need intense medical management? And I've had that happen a couple times where they're like, you guys were too good at your job and now they have no more medical problems. So, but it's not very common, which is why we need more rehab professionals in the skilled nursing facilities, because sadly, that's the way the world is going. ARUs are closing all over the country, and skilled nursing facilities are becoming more and more prominent and handling much sicker people.
So rehab physicians are now managing skilled facilities.
Mm-hmm. And so the company that I work for is national, and their goal is to have rehab physicians not just in ARUs, but in skilled nursing facilities all throughout the country, so that we can support your patients. And because an internist, they don't know about spinal cord injury. I would not expect them to know the ins and outs of taking care of spinal cord injury and neurogenic bowel and bladder and all of those things. So, hello.
How acutely do you get involved with these patients? Do you see them inpatient before the transfer?
I will, so right now I'm the hospital inpatient consultant, so they'll call me before surgery or after surgery. I'll usually know about a lot of these guys right right before surgery. So that my goal is to, as the inpatient consultant, is to get them ready for where they need to go. I mean, like recently we had a metastatic lung cancer patient. I think it was lung cancer. I knew about him when he came in the door, but he wasn't ready for me. And so I just watched for about a week as he went through his surgeries until he was out. And then I came in and saw him. But I could have come and seen him earlier too. So.
Great, thank you.
Thank you for your time, you guys.